Um, my name is Fayaz. I'm one of the senior trainees here. I'm going to present this paper which was published last year in BMJ. It was about intraoperative oliguria.
You have to mute yourself at the other end.
So, intraoperative oliguria predicts acute kidney injury after major abdominal surgeries. We'll go to the article, some results and some discussions and some limitations about the study they did. So at the moment, the threshold for intraoperative urine output is very unclear. My voice is coming back.
It's Jay. How is it not?
Yeah, fine. That's it. Still now.
Which one's which? This is our speaker. Yeah. Our speaker is off, so it doesn't affect them. I think so.
Nope.
Then?
I don't know.
Okay. So, the intraoperative urine output threshold is unclear. Some people say 0.5 mils per kilo body weight is a threshold for below which you should be thinking about acute kidney injury. So this was a study which was a retrospective cohort study in a relationship between the urine output during major abdominal surgeries like sections, esophageal surgeries, major laparoscopic surgeries, and the development of postoperative AKI, and to identify
but this thing records it as well, so
risk of AKI. As we know, the oliguria at the moment is defined as less than 0.5 mils per kilo body weight, but there is no evidence at the moment to support this urine output. Even the surviving sepsis campaign has dropped out the urine output as a guide for their resuscitation. So fluid resuscitation targeting higher urine output will lead to increased fluid overload, which will increase the mortality and morbidity in the hospital stay. And if we aim for the lower urine output, then renal hypoperfusion will associate with acute associated kidney damage. So we have to find a balance between fluids where we need to stick around. So the aim of the study was really to identify the optimal threshold. The hypothesis of this cohort study was there is a threshold for intraoperative urine output below which the risk of postoperative AKI increases.
with the neck query neck fashion.
And
Yeah, that's what I said.
Between the intraoperative urine output during major abdominal and the development of postoperative AKI, and then optimal threshold. This study was done in one of the major teaching hospitals in Japan. They did around 3,000 surgeries over in a year. So this was a single-center retrospective study. They took the patient age group up to 18 years and older. I think the maximum age was 93-year-old, and all major abdominal surgeries except any cardiac surgery and any urological procedure.
I'm hoping that I'm going to jinx myself.
If the patient was having
my next break is
in the same admission,
guys, can you turn your microphones off, please?
The next week isn't too bad.
So the exclusion criteria was if the patient had a urological procedures and the patient with end-stage renal disease. So in the hospital, they identified nearly 6,899 patients. After excluding these things, the number came to be 3,804. And that
that's what I wanted.
Is about 39. So in the end, they analyzed.
So far, I have
560.
But low battery.
So basically, the data collection and was all electronic, and which I think one of the limitations of this. So all electronic database and electronic medical record system, and the primary outcome was AKI. So how we defined AKI for this study was serum creatinine according to the KDIGO definition, which is if increase in serum creatinine of 26.5 millimole per liter within 48 hours, or 1.5 times within 7 days after the surgery. That was considered the definition of AKI. And the baseline was taken as the recent creatinine before the start of the surgery. So they did. They found this data and they plotted on the chart. So what we can see on this is, if you see, this is the male gender, hypertension, and diabetes mellitus. They got p-value less than 0.001. So they are a risk factor for AKI in the major abdominal surgeries. AKI class risk index again. If we remember, the AKI risk index includes age, sex of the patient, CCF, diabetes, ascites, all those things. And class 1 is basically if you don't have any risk factors or 2 of the risk factors, then the class 1. And class 5 is if you got all the risk factors, then they are likely to have AKI after the surgery. So the type of surgery again, was interesting that the laparoscopic surgeries were associated with more AKI after the surgeries, possibly because of the pressure effect and the duration of the surgery. If the pressure effect is for a longer time during the surgery, and they are more prone to develop AKI. The next one was the intraoperative blood loss. So the significant was if the intraoperative blood loss was more than 20 mils per kilo, they are again prone to develop AKI. The p-value is less than 0.001. And the urine output again, which was the basically primary aim for the study, they found that the urine output is significant. If you see the AKI was 226 patients, and the p-value is 0.009. So it's nearly 0.001, but they found it significant when they did odds ratio over this. So the results, out of 3,560 patients, 226 patients developed AKI with 6.3% and 95% confidence interval. Patients with AKI have a significant increase in in-hospital mortality. So it was 6.6 versus 0.8. So it is significant. And the prolonged hospital admission as well, which is for the finance of the hospital. So the results, patients who develop AKI had a higher AKI risk index. So as we saw that this slide. So the patient with high AKI risk index is class 5. They got more chance of having AKI. And more blood loss, as more than 20 mils per kilo body weight, and were more likely to receive intraoperative vasopressor infusion. So it wasn't mentioned about what sort of vasopressor they were given. It might be metronidazole or it might be the noradrenaline. Urine output in patient AKI was lower than in those without. So then what they did is, then they did its statistical cubic spline relationship. They plotted this one. So they took the first sample they took from intraoperative urine output from 0 to 4 mils, and then they plotted the probability of this with a 95% CI. So they found that up to nearly 0.3, the graph remains nearly the same, and after that the graph goes very up. And after this, what they did is they further broke this into the minimum p-value approach. So they broke this in from 0 to 1 mil per kilo body weight, and they found that at the moment we are running at 0.5 mil per kilo body weight, and even after 0.5 to 0.3, there was an increase in any probability of having AKI. And after 0.3, you can see the probability goes straight up. So from this graph, they found that 11.3% of patients had an intraoperative urine output of less than 0.3 mil per kilo body weight per hour, and incidence were 10.2 and 5.9. So it is significant, nearly double the patient got AKI after this. And so in this cohort study, basically is again and again same thing. Urine output less than 0.3 mil per kilo per hour was independently associated with post-operative AKI, and 11.3 patients had an intraoperative urine output less than this, and the risk of AKI increased by 2.7 times. So where from the 2.7 comes is the odds ratio. So they plotted an odds ratio, and there were two types of odds ratio. One was more than 0.3 mil kilo per hour and less than 0.3. With the more than 0.3 mil per kilowatt, the odds ratio was 1.37, which is not significant. But with the less than 0.3, the odds ratio is 2.7, which is significant. So the point estimated odds ratio intraoperative urine output was 1.37, which is substantially smaller than for intraoperative urine output less than 0.3. So the basically what they came up with is the widely definition of intraoperative urine oliguria less than 0.5 should be reconsidered, possibly we should actually, like if we look into the AKI risk index, there is not mentioned about the urine output during the operation. So we should actually include that as well in our risk assessment scores. So the limitations of this study were it was all electronic database and electronic medical record system. So we were unable to assess whether the intraoperative management target the unit output rate of 0.3 mil per kilo per hour will reduce the risk of AKI. So they couldn't actually figure out that more than this will decrease the risk. So we could not clearly determine the duration of oliguria. So there was not mentioned about the oliguria timing. And it was a single study, but it was a good study because it was a very big hospital. But we couldn't actually see, because in one of the particular hospital in the Japan only, we don't know, does this study apply to the other hospitals in the world? As I said, the findings may not be true for other surgeries. Like in cardiac surgery, we aim for a higher urine output, more than 1.5 mil per kilo per hour. So that's different for them. So we will look at further studies to determine the optimal threshold for unit output in various clinical settings. Thank you.
Thank you very much.
It was about the statistical. Sorry, it's a bit complex. It takes a bit of time to understand.
I'm going to turn the volume back on in case there's any questions.
Did they suggest, so suppose you have the patient on the table and the urine output looks like it's low, less than 1.3. Did they make any suggestions about what you should do about it?
They didn't suggest, but generally the feeling of the article was that we should aim more than 0.3.
What can you know about it? So is it vasopressors? You said you want to overload it, which I agree. But then you said vasopressors also is a risk factor. So
Yeah, I know.
what can we do about
I
it?
think they didn't mention it, but I think it will depend upon the type of the patient. I mean, are we going to fluid resuscitate the patient? Are we going to use the vasopressor? As I said, vasopressor is again a risk factor for AWM AKI. Yeah, I mean, they haven't actually mentioned about it.
I think, well, I mean, don't drink colorectal. I think they still have the policy they don't want to give too much fluid.
Too much fluids, yeah.
So,
But definitely, there were quite a few things like vasopressor is one risk factor. So we are like widely using vasopressor, but it's a risk factor. Blood transfusion, yes, it is again a risk factor. The laparoscopy we think is like it doesn't have any problems, major problems, but AKI is associated with the laparoscopy procedure. So there were quite a few other things which came up with the article, which were interesting.
They assessed the fluid status, and what was the cause of oliguria? Was it hypertension or was it?
No, they didn't. This was all. The problem is, it's all retrospective and electronic database. It's very difficult to get anything from the database about how much was the duration of oliguria and what was the cause of it. That's the problem. I don't think. I think they're muted.
enhanced recovery for colorectal and what the instance is.
So the question is, are we going to? I mean, it's because we don't normally for our laparotomies, how often we measure our urine outputs regularly to make sure that we're not running behind, fluids or behind resuscitation. I think that was one of the outcome from this article, that at least make sure that 0.3, okay, if the 0.3 is not coming, what I need to do is vasopressor or I need to fluid resuscitate? Do we have any more chances? It's quite often we start laparotomy without CVP line. I know CVP is not the best indicator, but still it is somewhere where you can rely on a little bit that, okay, I need to see the fluid resuscitation status of this patient.
I think particularly laparoscopies, people are less inclined to
Put the CVPs, yeah.
Less patients very high.
In the cardiac patient, they will.
Or, and I don't know how accurate the doctors are. With laparoscopic surgery. I have no idea. I don't think that would be very useful.
In my hands, they're not accurate, full stop.
If it's laparoscopic surgery, it might be even worse.
Yeah.
So,
does it relate with regional and oliguria? Because we do give a lot of spinal for colorectal surgeries, particularly laparoscopic surgery. We give spinal energy, isn't it?
but that's your regional is for pain relief. It's not you know.
Could be some systemic hypertension.
Yeah, well, that can be, but yeah, that's a valid point. But again, if you give a spinal, your blood pressure drops, then you fluid resuscitate them or use the vasopressor, isn't it? You don't keep the blood pressure down. And again, the major question is that do we always recognize the patients who are prone to develop AKI? Should we start to develop a habit of looking into the patient's notes first? Okay, I'm doing this laparotomy during the night time. What things I should do in order to at least avoid AKI in post-operatively, which is again mortality and morbidity risks.
I suppose if you look at your emergency cases, they may well be going to an HDU, ICU environment anyway, so it's closely monitored and it's going to be acted on. But it might be quite helpful for some of your slightly higher risk elective cases, whereby it's that extra rationale for monitoring afterwards, isn't it?
So they'll get early urine outputs afterwards.
That's also.
They get 4 hourly, isn't it? 4 hour, which is just not the. And after 4 hours, you get a call that mu score is now high because they run the behind resuscitation or they run behind.
They don't get hourly back, isn't it? They just.
I mean, how often we see the patients post-operatively call for the ITU that patient got AKI now. So that's not a very uncommon thing to happen. But that again comes to us that are we more vigilant? Did we what we should be done with the best for the patient to start with? Thank you.
Thank you very much.
I think what he said.
Yeah, I think
what the other who was on the other side.
I think he was Matthew Reed and then some of the guys from Solihull.